There are times during surgery when you discover a way to make things easier or more efficient. Sometimes there are through our own quicksand moments. Others are surgical gems gifted to us by our mentors and peers. This is OQC Eureka Moments with Doctors Nicole Fram and Elizabeth Yu, where we learn how to pivot, reflect, and evolve as surgeons. Welcome, everyone, to the 6th episode in Season 3 of Ophthalmology Quicksand Chronicles Eureka Moments. We are your hosts. I'm Dr. Elizabeth Yu. And
I'm Dr. Nicole Fram, and we're so excited to continue Season 3, which will focus on those moments that we take away from quicksand cases. And Liz, sometimes I'm in surgery, as we talk about all the time, and I'm just falling. I'm just going, wait, let me do it with my chair. I'm going deeper into quicksand like that. And I just need to remember these surgical gems that can help us get out of quicksand.
yes, and you know what? And so I have lots of people who have come up, which is so great to hear that they've learned a lot from the Quicksand Chronicles. What I love is that we have to remember that the Eureka moments is that pivot. These are shorter episodes. They're the surgical pearls, the gems, those things that have been passed down to us, the things that we hear in our ears and in our heads, that we learned either from our mentors or that we've learned through experiences that we want to pass along to you, those techniques that have helped us speed in our learning curve, that have been gifted to us by our mentors and our peers.
Yeah, it's the combined experience, right? It's whatever you learned from your residency director, your fellowship director, your um, mentor in the practice that you joined. It's that moment where you're in surgery and it goes directly into your ears and out your hands. And it's just joyful. And that's what Eureka Moments is about.
That's right. And so hopefully we don't get stuck in the quicksand because of these moments. And as a reminder, this season will be available through video and audio podcasts. So you can listen on your favorite platform and watch on YouTube, no longer behind the firewall. And at the end of this podcast, we would love for you to fill out the short survey that is in the description below to help us understand what you find valuable so that we can integrate this into future episodes. So we would love to introduce, we're so fortunate, we have just some of the world's most gifted surgeons who join us for these episodes. And today we have one whom we discuss and bring his name up all the time throughout multiple seasons. And it is none other than, drumroll please, Dr. Sam Masket. He is a New York native. Dr. Masket is a clinical professor of ophthalmology at the Geffen School of Medicine at UCLA and a founding partner of Advanced Vision Care in Los Angeles. He also founded the Samuel and Barbara Masket Foundation, which is amazing, a research and education arm of Advanced Vision Care. He has served multiple organizations in the past, including as past president of the ASCRS, the Board of Trustees of the AAO, and as an associate examiner for the ABO. Dr. Masket has published well over 100 peer-reviewed publications, as well as 2 textbooks. And certainly we know that he is truly a maestro within the operating room, and he's been honored with too numerous numbers of named lectures and awards from his peers, well-deserved. We are thrilled to put him in the hot seat today, and I'm going to turn this over to his partner, Dr. Nicole Fram, to say a few words.
So there are actually no words to express my true admiration for this person. I've been lucky enough to do an apprenticeship with Sam Masket, and besides being an incredible surgeon, an incredible educator, he is the most generous person I have ever met and the most patient person I've ever met. And we are so honored to have you here with us today, Sam. I'd like to remind everyone that this podcast is all about the moments in surgery that, sort of change us and make us into better surgeons. And Sam, we'd love for you to share your Eureka moments and help us understand how to be better surgeons.
Well, first of all, I want to thank the two of you the kindness that you express, number one, and for inviting me to participate in this program. I firmly believe in what you guys are doing, and it's so wonderful. If we can save a young surgeon a lot of time in the learning process by presenting, how we got to where we did, that only helps our patients. And that's really what the, the bottom line really is. We want to help our patients. So I'm really thrilled to be here with you today, and I'll try and share my Eureka moment with you, how it came to me, and why I think it's important. Every so often we get kind of trapped by our patients who may have expectations that are a little bit beyond what we think we can approach, but where it's not a hard contraindication. And this case represents such a situation. I also really like this situation because it addresses the controversy of whether a CTR has value postoperatively in a patient with a progressive zonulopathy, and also whether or not we can consider using premium, that is toric or multifocal IOLs, in patients who have zonulopathy. So this is the second, or the left eye, of a lovely 70-year-old man who had clinical pseudoexfoliation in this eye, but his fellow right eye did not. Both eyes needed cataract surgery. He had no other problems, but he was really motivated for spectacle independence. We discussed this at great length. I said, your fellow eye has a wonderful prognosis, but this eye may develop problems because of your pseudoexfoliation, either during surgery or afterwards. He couldn't be dissuaded. So this is the surgery in the left eye when we place the multifocal IOL. As you can see, his pupil doesn't dilate well because of the pseudo-X, so I placed a Malyugin ring. And just to demonstrate there really wasn't significant zonulopathy at all during surgery, we're completing the manual capsulotomy and doing what I like to do, that is vertical or quick chop, phacoemulsification. Notice that the lens seems stable. There's just no real concern about it behaving abnormally. And the same thing here during cortical removal. The capsule is stable and centered. So I was feeling quite comfortable that we could achieve his goal. Because I believe firmly in cleaning the subcapsular LECs, you see we're using a Singer sweep here to do that. And I do it rather compulsively in an attempt to prevent later fibrosis and phimosis. And here manually, I'm placing a standard CTR in the capsule bag, although the bag is, as I mentioned, well centered. And then putting in a multifocal IOL. And here at the close of surgery, you can see the IOL is well centered, setting pressure at physiologic levels, and surgery is completed. So he was quite happy for a number of years. And then one day, he shows up to my doorstep looking like this. So here now, this is that very same eye, only the arrow points to the top edge of the IOL. So he has a very significant inferior decentration of the bag, IOL, and CTR complex. And I think you can see here there's some pseudoexfoliative material, which is very typical. Although there's really not a lot of changes in the capsule here because of the extensive cleaning of the subcapsular LECs. Well, I'm now challenged with the concept. I've got a patient who's got one eye with a perfectly centered multifocal, very happy, and he's not doing very well here. Now, most people looking at this would probably consider taking the lens out or suturing the lens to the sclera by lassoing the haptics. In my experience with two-point fixation of lassoing the haptics, you really can't guarantee the centration that you need for either a toric IOL or a diffractive optic IOL. So I have, prior to this case, I have lassoed the CTR to the eye wall, taking advantage of its presence. But faced with what to do with this man, where I know I needed really good centration, I gave extensive thought what to do. And my eureka moment for this man was the thought, you know, Charlie Kellman always taught us that 3-point fixation of an IOL, be it in the angle or what have you, is always more stable than 2-point fixation. So I thought if I could fixate the CTR, not the haptics, just the CTR in 3 points, and if I used adjustable suture technique, then I could, you know, just gradually get that lens exactly as I want it, bury the knots, and then go home. So we can run the video and we'll take a look and see what happened. So here he is, obviously, again, a poorly dilated pupil. So I'm going to mark the eye 120 degrees apart in 3 locations. And that's where we're going to fixate the CTR. Placing iris hooks because we really don't see very well with the poor pupil. And one choice is Hoffman pockets, but I prefer here to take down the conjunctiva. And let me just freeze it right here, because that's something that you can see really readily. Notice I'm going to go back about 3.5 millimeters from the limbus. This is a suture material that's no longer available. Probably if I did the surgery today, I'd be using Gore-Tex. But here I'm using 10-0 polyester suture, which I was assured was non-biodegradable. And what I want you to notice here is that the first suture goes behind the bag and then through the bag behind the CTR, but in front of the haptic. I'm not interested in the haptic, just the CTR. And I'm going to bury this into a 25 gauge needle coming from an opposing paracentesis. Now we have other options. We can thread a suture in as Steve Safran describes. We can use a snare as Gary Condon described. But this is, there are any number of ways to place a lasso suture, and this is just among them. So I'm going to bury this needle, which is again on the polyester. I'm going to bury it into the 25 gauge that comes through the paracentesis. And now about 1.5 millimeters anterior to that first pass, I'm going to place this 25 gauge needle on top of the bag, just under the iris. Then I'm going to turn the needle around, pass it through the paracentesis, being careful not to catch any corneal fibers, and then bury it into that 25 gauge needle and bring it out. And then when I pull the suture, I notice that the whole complex moves, meaning that I've achieved a lasso. And then I'm going to do the same thing in the other 2 locations. Again, here under the CTR, and there are no haptics here on the infratemporal side. So I'm just under the CTR. And again, watch as I pull the suture, the bag complex moves. That tells me I'm in the right place. And now we're going to do slip knots. After I do the slip knots, I'm going to take out the OVD from the chamber. I'm going to make the pupil as small as I can with an intracameral miotic, and then progressively tension the sutures until I like the centration. And once I do that, then I'll tie them, cut them short, and bury them. And then here at the close of surgery, I like to check all my incisions to make sure they're properly sealed. And I like to use fibrin adhesive for the conjunctiva. And you can see how nicely the lens is sutured and centered here at the close of surgery. So let's move on. And then here, I hope you can see this. This is the undilated pupil postoperatively. And you can see the rings, the diffractive rings, are just dead on. You can also see, obviously, the pseudoexfoliative changes around the pupil margin here, as well as the dilated postoperatively. Again, a very, very well-centered optic. And I think the key here is not just the 3-point fixation, but also that the sutures are radialized so that you don't induce any torque or any twisting of the CTR. So the moment to me came in the surgical planning. How can I assure this patient that I'm going to recenter this IOL and give him the same quality of vision that he had before?
Well, Sam, I mean, your attention to detail does not go unnoticed. I've seen that throughout my whole experience with you. I think that the hardest part is that there's been a lot of literature that's come out to say that putting a CTR in does not cause the complex to not dislocate over time. But you're giving us another reason to expand what type of IOLs we can use and to use it as a preventative measure. How skilled does a surgeon have to be to do these kind of lasso techniques?
Let me just back up a moment. I think, again, why I said I really like this case is because it shows that there is value in placing a CTR, even if it doesn't prevent capsule contraction or fibrosis, which I don't believe it does. But again, the reason to place it is if you need to use it postoperatively to center the bag. To be honest, it's hard to judge anybody else's surgical skills, but I don't think that anything that we do here is outside of the skill of any, anterior segment surgeon. I think one of the things that I am aware of is that there's a progressive number of patients, almost an epidemic of these cases. I think residency programs are really not teaching this subject as well, which why I think what you're doing here is a great service to pass management of complex cases on to our younger colleagues. But as you mentioned, this expands our ability to use lenses of this nature in patients with potential zonulopathy. And one of the things that we've learned very, very specifically is that patients really are motivated for spectacle independence, sometimes even over quality. So I think if we can increase our indications for use of toric and diffractive optic IOLs in patients with zonulopathy by placing a CTR, then I think it's valuable to do it. With respect to the skill, I've got a lot of experience, so maybe I view it as nothing difficult, but I really don't think it is.
Right. So I think that there's a few things that are such great takeaways right now, because when we do assess these patients, and one, there's progressive versus a non-progressive zonulopathy. So if it is something where we notice at the time of surgery that there's maybe 2 missing clock hours of zonules because we tugged with the IA process, whether or not you put a CTR in, that's maybe not necessary per se. But if you know that it's a patient with pseudoexfoliation, I like to, in any patient with pseudoexfoliation with any type of IOL, I like to make certain that I'm either utilizing a 3-piece IOL, or that if it is going to be a patient where I'm moving to a 1-piece that is an advanced technology, I have been more reserved about considerations for a lens that requires that exact centration because of that progressive nature or that potential for decentration in the future because of exactly what you showed. So I've been hesitant in the past, unless I was willing to, at the time of surgery, do a scleral fixation and something a little bit more advanced, just to ensure that in the future, there was not the concern of a potential dislocation. But I think that this is such a great point. And then let's talk a little bit about, I love the idea of the type of sutures that you're recommending, because now we're talking about different ways of scleral fixating the CTR, or lasso fixating a lens that has become dislocated, or a lens bag that has become dislocated. There are the flange haptic techniques. There are different sutures. We don't have sutures beyond the Gore-Tex that do not necessarily have the potential to dissolve away. But I'm going to tell you, like the suture you used, or like a polypropylene suture, or Gore-Tex, those are very easy to titrate. And then there's the burying of the suture, which is going to be somewhat sclerostomy size dependent. And with a 25 gauge or a 27 gauge, then it's a suture thickness dependent. I think that is preferred over utilizing like a flange technique where titrating is just not as easy. What are your thoughts there, Dr. Masket and Nicole? What are your thoughts there?
Well, if you ask me first, um, I've always had a problem with the concept of the flange with regard to titration. You know, you keep cutting it shorter, cutting it shorter, cutting it shorter, and then all of a sudden it's too short. What I like about adjustable or slip knot suture technique is you can keep titrating and you can unloosen and retie and what have you. So given my choice, I prefer the precision with which you can use sutures, particularly 3-point fixation. So we can get into conversation about the flange. I'm also concerned that people leave big flanges in the subconjunctival space rather than buried in the sclera, and that's also a potential problem. So I prefer sutures that are buried. I know that many people using Gore-Tex will make a groove so that it is not subconjunctival, so it'll be definitely within the sclera, and I think that's something I know Nicole does that routinely, and that surely is protective to the patient. But my sense is that we can be more accurate with suture tension titration than we can with flange.
Yeah.
Yeah. Liz, I think you bring up a great point. It's really hard. It's all based on your experience and what you use. I mean, some people feel that 10-0 polyester, which is not available, or 10-0 polypropylene, or even 9-0 polypropylene is hard to work with because you can break it so easily. And unless you have an area that you made either with a 25 gauge needle, at least in one of the sclerotomies, it can be hard to bury. But the beauty of it is you can leave the ends long and leave it under tenons if you can't bury it nicely. So, that's one way to get out of it. As I use Gore-Tex, the issue with Gore-Tex is that you have to have at least one of those sclerotomies of the radial fashion having an opening that's at least 25 to 23 gauge equivalent. And
That's
the
right.
thought of making that in 3 places or 6 places seems like a lot of hypotony that can happen after. So I think about that. So the way, if you really look back at the way Dr. Masket did, or Sam, what do I call you? Sensei. All right, my sensei. The way that he did one with the needle and then the other side with the 25 gauge should not go unnoticed. He did that so he could bury the knot more easily. He doesn't say it. That's what I'm here for, to say it. So I think that that's really important. As I do more flanged IOL technique, I'm learning how to titrate, and you can get there. What I would use on this case if I was doing flange would be 7-0, right? So I would do 7-0 polypropylene in order to have a smaller flange that you can, and I actually tunnel like a millimeter into each sclerotomy to kind of make an angle there so I can bury more easily. So I think this can be adaptable to whatever, technique you want to do. The point is just do it safely and make sure you have practiced with that material prior to doing something like this that is not as forgiving.
Right. So a couple of pearls there, and these are such great points that are being brought up. So we're going to be doing vertical mattress lasso sutures. So because it's a vertical mattress style, and as Sam brought up, it's going to be about 3 to 3.5 millimeters behind, and the one anterior is going to be about 1.5 millimeters behind. So it's about 2 millimeters in size, in the length of that vertical mattress. Now, if you want to make it easier to bury, at least one of them you can score, at least so that if that sclera is scored, the knot can at least be a little
Sit
bit
in there.
easier
Yeah.
to sit in there. And then if you're going to do kind of a docking method with a 25 gauge needle, as Sam had mentioned, and as Nicole mentioned, that allows for one of the sclerotomy or sclerostomy sites to then be larger to allow for burial of the suture knot. With that being said, the 9-0 will break less in the polypropylene suture. With the Gore-Tex, you truly do, unless you're going to be using the needle for one of them, you do need to enlarge one of them to at least use an MVR blade, because you're going to need to go in
Fully.
with exactly fully. With I actually say 23 to 21 is the more comfortable size in terms of the gauge of your sclerostomy, in order to actually engage into and grab the Gore-Tex to create the lasso, and then allow for easier rotation into the eye. And truly, whether you go 7-0 or 6-0 for that intrascleral or intrascleral haptic to flange that, when you lasso that, it's stiff. And it is a little harder to titrate. With the 3 points, you will have better centration. But if you only do 2 points, it is more challenging to titrate that. So just keep that in mind, that lasso fixation using the sutures versus the intrahaptic, I think from a learning curve standpoint, certainly makes a lot more sense, particularly using a CTR versus trying to capture an optic and a haptic junction, etc. It certainly is a lot easier. And this is such a great Eureka moment, Pearl.
A last pearl that I would say is that before you start the case, if you have any digital marking system or Callisto and you have a reference image, I've been marking the center of where the centration is based on their reference image. And then as you're titrating it, if you don't have a CTR and you're just lassoing at the haptic optic junction and informing them, if it's not centered, I'm not going to keep the lens, you can then center it on that mark that you made on the cornea and know that when the pupil comes down, that you've centered the central ring on their actual visual axis. So that's been a recent thing that I've been doing. You can also mark them at the slit lamp and look for them to look at the visual axis preoperatively if you don't have a digital marking system.
Oh, that's such a great point too. All right, Sam, any takeaway pearls that you'd like to share with regards to kind of what you do to make sure to maximize your outcomes with patients who have those expectations in progressive zonulopathy patients?
Well, again, if you have a patient, particularly pseudo-X, because in some populations it's so prevalent, but any patient who has pseudo-X, where you're using a one-piece lens or particularly toric or considering diffractive optic, place a CTR. Routine placement of CTR at the time of surgery is really very, very low risk and also low expense, but it gives you a great handle later on, number one. Number two, in any patient with a potential for progressive zonulopathy, try and clean the LECs as well as you can. That'll probably slow the process down. And then, you know, I know it's really, really sexy, the flanges. I mean, we all fell in love with Yamani's technique, and then people adapted it to other situations. But if it's me, if it's my eye, I would prefer to have a titrated suture than to have a flange.
Great.
Excellent.
Well, thank you so much to everyone for listening to this episode of OQC Eureka Moments. We hope that sharing these techniques will help speed that learning curve and pass down the gems that have been gifted to us by our mentors.
And please remember to email us at quicksandchronicles@ascrs.org with any questions, your feedback, and your comments. And don't forget to fill out the survey that is below.
And remember, every time you think you have the eyeball figured out, it will humble you.
And we hope these collective experiences will help you, me, all of us develop that grace under pressure. Thank you, and we'll see you next time.
Bye-bye,
Peace.
everyone.
Bye-bye, and thank you.
Thanks for joining us for this episode of OQC Eureka Moments with Doctors Nicole Fram and Elizabeth Yu. Hindsight really is 20/20.